I think we're at a good spot, and what I'd like to do is go ahead and we'll introduce the first speaker. It's been rather interesting, if I might, because what we did is based on your topics, we actually went and across the entire organization, we put together a team. These aren't teams that always necessarily even work together, okay, in the sense that they're working in different areas. Every one of our research centers was represented on every one of these teams. All of our major research emphases were represented on those teams. I will say that just as in my office as we were putting all this together, we were a little out of our comfort zone, okay? And Jennifer, we were a little out of our comfort zone, weren't we? A little bit, okay? But I have to say, as the team put that together, we didn't want to have a lot of direction. We didn't want to have a lot of this is the way to do it. We wanted them to be able to come together and think about it, bounce ideas off of each other in different ways. And I think that you're going to see that when you see it. Carl Jung, the Swiss psychiatrist and psychotherapist, said, the greater the contrast, the greater the potential. Great energy only comes from corresponding great tension and opposites. And you'll see that with our speakers. So I'd like to go ahead and introduce our first speaker. And each of our speakers are really representatives of a larger group that are here. The first is Dr. Don Sin. Don is the divisional head of respiratory medicine at St. Paul's Hospital, a Canada Research Chair in COPD, and professor of medicine at UBC. He has published 350 peer-reviewed articles and has written numerous editorials and book chapters. He serves on the International Gold Scientific Committee for COPD and is associate editor of the journal Thorax. You know, I was reading that today before I came over. Thorax. His interest is in finding biomarker solutions to address the growing burden of COPD in Canada. In 2014, he was ranked as the top COPD expert in North America and second in the world on expertscape.com. Pretty impressive for St. Paul's in Vancouver, isn't it? Don will speak on behalf of his team that explored the survey most requested topic, establish a health outcomes and health economics center for personalized and P4 medicine. Don.
Well, thank you very much. I was asked to start the discussion on personalized medicine in 8 minutes or less. And somebody in our group said, 8 minutes? That's way too long for this presentation. So here we go. So I just wanted to start a conversation on personalized medicine. Some people call it P4 medicine. And recently, personalized medicine has become synonymous with genomic-based medicine. And I think that's really too restricted. So I like to use a different term called precision medicine. And I'll define it this way. It's really getting the right therapy to the right patient at the right time using, and here's the kicker, state-of-the-art technology or repurposing existing technology to address a growing burden in the healthcare system and improving the health outcomes of our patients. One of the, I think, major pressure points in our healthcare system is certainly the hospital. We spend an enormous amount of money trying to take care of chronic, non-communicable diseases. If you look at any major hospital across Canada, the top 4 reasons for hospitalization are the following: chronic obstructive pulmonary disease, heart attacks, pneumonia, and heart failure. The commonality, there are several commonalities among the top 4, and they account for anywhere between 1/4 to 1/3 of all medical hospitalizations. One is that they're either heart or lung related. And the other one is the way in patients present to the emergency room. They don't come with a band over their forehead saying, I have a COPD lung attack. They come in complaining of shortness of breath or cough or chest discomfort or chest pain. So they come in through congested emergency department having these symptoms. Traditionally, we would do the slow approach, taking a history, physical, and so on and so on. But in this era, where our healthcare system is so pressured, that results in tremendous delays in diagnosis, sometimes misdiagnosis, leading to poor health outcomes. So how can precision medicine help this? Well, we can try to discover diagnostic biomarkers. What are they, and how would they help? the patients will still come into emergency room or maybe urgent care facilities, complaining of shortness of breath, and they would have a variety of different diagnoses. Some may have heart failure, COPD, pneumonia, heart attack, blood clots, so on. If we can develop a simple point-of-care testing that has a rapid turnaround and highly accurate, then the emergency physician can order that and then segregate the patients according to what they really had and put them on the right therapy at the right time, resulting in improved health outcomes and reducing the congestion in the hospital and hopefully getting them out sooner rather than later. So that's what precision medicine is all about, enabling. Well, we have another problem in this country and elsewhere, which is with medications, which account for about 15% of all direct healthcare expenditures in this country. And the problem is that they're sort of effective. They're highly effective for a select few. They're not so effective for another select few. And then in the middle, so-so efficacy. And it also depends on the therapeutic area. Now, these data are a bit old. It's about 10 years old, but I think it makes the point. Even in under the diagnosis, say, of COPD, there's tremendous heterogeneity in the disease process and the way patients express that disease. And therefore, giving one drug, saying this should work for all COPD patients, is just not realistic. In fact, on average, 70% of those patients will not respond the way we think they will respond to the drug. And this obviously leads to waste in our healthcare system, but also bad health outcomes, including hospitalization and even death. Well, how can we overcome this? And again, this is where precision medicine can help. And this work has been pioneered by Julio and his group in the Center for Excellence in HIV and AIDS. You would think that HIV is one disease. What's the problem here? But the virus can develop mutations and other changes that make them resistant to certain drugs, but not to others. So using, in this case, genomic approach, they've been able to segregate the HIV virus and the patients into different categories and put them on the right drug at the right time. And this leads to better outcomes, less waste in our healthcare system, and overall, tremendous benefits to the patients. The skeptics always of personalized medicine, precision medicine, argue that it's just a money drain, that technology only brings more waste. And that's true if it's not done correctly. But there are examples now of pharmacogenomics and pharmacoprecision medicine where we can achieve savings if we do this right. And here's a few emerging examples. Why St. Paul's, or why Providence for precision medicine? Precision medicine obviously can be done everywhere, but it can only be done well in certain centers. Certain centers that have certain domains. The most important domain is having a very, very strong clinical program that is focused and well organized. And we have that. And I've listed a few examples: COPD, HIV, heart failure, and so forth. The second is engaging the patients as partners in the research enterprise, in the innovation enterprise. How do they do that? Some of our patients donate their blood or their urine or even their lung biopsy samples for research. Patients as partners in this enterprise, creating huge biobanks that Julio has used for his research enterprise, that we have used in our COPD enterprise, and that makes all the difference in the world. Biomarker discovery and therapeutic discovery also cannot be done in isolation. It has to be done under an economic framework that makes sense to both patients and to the payers. And you've got to have huge computational team to harness the big data that's generated from the omics revolution. And we have all of that within the walls of this center. And let me give you an example of how economic analysis can help guide therapy, as Minister Wilkinson indicated previously. And I'll go back to before I do that, let me say a few words about our economics platform, health economics platform. You can't do it from the side of your desk. You really need a cadre, a core of dedicated health economists who understand the issue, can not only crunch out the numbers, but understand the clinical issues of that therapeutic area. And we have that. In fact, we're the largest group in all of Canada that can do this job right in-house. The other, I think, major strength, and again, Minister Wilkinson alluded to this, we have a tremendous, not only internal databases of our patients, but administrative database that is fairly unique. In fact, we're the only big province in Canada that can track drug records of every resident in British Columbia, from infants to the 95-year-old. And how is that helpful? Well, let's go back to what I know best, which is COPD. This is how our COPD biomarker program was generated. Our health economists told us that in British Columbia alone, we spent nearly $1 billion in excess costs looking after COPD patients. $1 billion out of the $19 billion that the ministry spends on healthcare. If you look at per patient costs over years, you see one line that dominates all the other lines. That's the red one. That's hospitalization. And it's growing, and it's growing rapidly. So how should we tune our biomarker discovery program? Well, if we are going to do this, we have to discover a biomarker that can reduce hospitalization. That's the key here. That's the key. And that's how we focused our biomarker discovery platform. And Alan Winter is in the audience. We applied to Genome BC in Canada and got a grant to solve this problem. So why us? I think I've summarized that already. I've listed here just so that you know. I can't stress the importance of integration and institutional support in this enterprise. It cannot be done in isolation. So precision medicine is all about enabling the physicians to get the right therapy to the right patient at the right time to improve the health outcomes of our patients. So before I end, I just want to leave you with a few questions so that we can start the discussion. It's not about a lecture, it's really about a conversation. Are there value, or is there value in biomarker-driven precision medicine? Can we afford it? What are some of the unique strengths in BC to enable precision medicine? What are their barriers? And surely there are many barriers. Are there any partnerships that we can forge now or in the future to enable and implement precision medicine here in BC? Thank you.
Don, thank you very much. You remain up here.
Oh, okay. You want me to?
So we're going to open this up for some questions and dialogue. And think about it in the context of several things. There's some questions that Don had provided. We're talking about starting to really look at some topical pieces that will actually inform what might the research questions might be. We're trying to think in a 12 to 18 month time frame. So what might it be? What should we be thinking about? If you want to help us figure out what those research projects could be, what those pilot projects could be, okay, that fundamentally will start to make a difference here, what might it be? If this was really easy to do, okay, we'd always be doing tons of this now in the public healthcare system, but we're not. Yes? Oh, and if I might, what you do have is in front of you, you do have a microphone system. What I'll ask is that you identify yourself and your organization. If you just press the bottom of the ring that's around there, it'll light up. And if everybody starts pressing that, what'll happen is you'll actually blank everybody out. So what we'll do is we'll sort of recognize from there. Just press it and it'll go red. Press it and it comes off. Yes?
Hi, I'm Judy Hess, CEO of Copperleaf. I have a question for you. In terms of understanding what the value of this will be, I was wondering if you've looked at the criteria for that value and tried to either monetize or understand how to determine what that criteria is, and then what the value that would be when you're creating the return on investment and calculating whether or not this is the best project or the right way to approach this project, or what other alternatives there might be. And I didn't see a list of criteria and the value that that criteria would bring. I mean, it can go all the way from financial benefits, of course, but also there are non-financial benefits that might be taken into this that can improve outcomes.
Okay, so I'll ask Don, or Don, there's a number of your team members here, if there's somebody that might...
I can speak from our experience, and please feel free to chime in for those who want to chime in. When we start any sort of research project with regards to precision medicine, we need to ask those fundamentally important questions. What value are we bringing to our patients, to the payers, to the hospital, to society in general? And we undergo, in our case, we underwent an extensive modeling process using largely administrative health data, but not exclusively, even patient-level data, and then projecting out, because precision medicine is not just about today, it's about tomorrow, and projecting out what the value on investment will be over the next 5 to 10 years. And we did this for the Genome Canada project, and it was clear that the one area we had to tackle to get this right was hospitalization or emergency visits. And so we had to tune all of our research endeavors towards that. And there are certain targets we wanted to meet to bring that value, to realize those values. And we set out those targets. And we're in year 2 of a 4-year project, and we're meeting those targets. But it has to be done, I think, in that context, and not in isolation. Otherwise, you're quite right. You develop a product, but may have very little value for the organization, for patients, or payers. So, and I'm sure that's the same for the HIV domain and many others that happen here. So, Julio, I don't know if you want to comment on.
Others from the audience, yes.
Hi, in regards to, my name is Michael Bido, I'm with Sanatron. The last question there, are there any partnerships that can be forced to accelerate precision medicine at Providence? My question is, what is your vision about engaging the citizens of British Columbia in this process? Not just the healthcare system or the doctors or the physicians or the geneticists and so on and so forth. What's your vision about engaging the citizens?
So I think you bring up a very, very important point, and I was just at a CIHR meeting, and at every level now, CIHR and other organizations are insisting that patients be part of it, not just as a token representative, but as an intrinsic part of that research enterprise. To be honest, in our Genome Canada COPD project, we didn't really do that. We obviously, got feedback from patients, but they were not part of the design and execution of that particular project. And if we had to do it over again, we would change that. And I think, and I'll get to Aslam in a minute, any projects that I think arise must fundamentally engage patients and other stakeholders in that process at every level of the research execution. Aslam, I think you had a comment about that.
Thanks, Don. I'm Aslam Anis, and I'm a health economist, and I'm the director of the Center for Health Evaluation and Outcome Sciences, and one of the people who work with Don in putting together this topic presentation. And I want to answer both the questions that were raised. First of all, we have in our group expertise to look at new innovations and ideas that are not fully developed and the potential is unknown. And we can do different kinds of informational analysis known as value of information analysis that assesses the return on investment for the manufacturer, that under various scenarios look at what the payer is getting and what the healthcare institution is getting. And part of what we do, and this goes into the second question, is that we are developing, we have a group of people who who are very involved in shared decision making. So there's a lot of new literature on shared decision making, nudge theory, how to engage patients, how to give them information, and not only based on just giving them information, but based on their literacy, based on the ability to process the information, how they make those decisions that are good decisions for them and for the healthcare system. So just to answer both questions, we have a group of people working in this area of health outcomes from the focus of shared decision making, and also from the perspective of knowing the economic value of uncertain innovations.
So if I might, with some of the things that you've heard, what are the questions we should be asking? Are these the right questions? Are there better questions to ask? If you were making decisions about this and what we were to do, what are the right questions to ask?
Yes.
Yes, please.
Well, when I think of, I'm going to call it the pharmaceutical industry over the last 20, 25 years, I look at how molecule and molecule development has progressed, how things have changed, how they've moved to specialty medications, biologics, how they've priced them. And yes, there's been rationalizing in that industry like there is in every industry, but they've done very well. To me, I take a look at personalized medicine, and it absolutely makes sense to me. We're all individuals. You hear stories about people that do research. They take molecules, or they measure them in individuals, and we all react differently to them based on our chemistry. So looking at people and how they react to medicine makes sense. So I guess the question that I'm asking is, if this makes sense, and it makes sense, and others in profit versus not-for-profit are doing it, and doing very well at it, finding niches to develop and sell and price it appropriately and make good money, are we looking at it correctly? Is there some way that we can look at it in a for-profit model, perhaps, rather than a not-for-profit model, and engage partners and or funding or something that would allow us to move along this path better and or quicker and or more successfully, et cetera.
Okay. Some comments about an economic model. What do you think about that? Is there an area that we should explore? Excuse me, the young lady in the near front row here, who also is my boss as the chair of my board.
Young being operative. So I think one of the models that clearly that we look at, what we employ at CDRD, of course, is this risk reward share and partnership with everybody, so that everyone who has a skin is vested, who is a stakeholder has a skin in the game, and that includes, by the way, patients through the foundations, but to bring industry, the appropriate industry to the table, to avoid replication, because one of the things, you will obviously know what's going on in the scientific community, but how would you tie in to industry and know what's going on and how far advanced they are in a particular area? And I think one of the key things collectively we want to do, not just here in BC and Canada, but globally, is stop the replication and duplication of resource, because that can be applied to other things. But there should be a partnership and a risk-reward approach to this. So, how would you tackle that, and have you considered that, to ensure, A, there's no duplication, B, that we can partner with industry, with foundations, with other groups, other stakeholders, so that it's a collective approach, but to the question asked before, that there is a risk-reward element to that. So it's not just that the reward goes then to industry alone.
I think you make all relevant comments, and it is, coming from an academic background, we are quite naive to what's happening in the private sector. And so having these kind of conversations between academia and private sector and patient groups and so forth are, I think, very instructive and helpful for all stakeholders involved. Having said that, from an academic perspective, one of the things that we really take pride on is transparency and openness, both in terms of collaboration and data access. And for the most part, the private partners that we've engaged are also open to those things. Obviously, there are some IP issues and so on that stand in the way of maybe 2% or 5% of the conversation. But most of the time, I think if we follow those basic principles of openness, transparency, having continuous dialogue, communication, and so forth, I think academics can work in parallel with the private sector. And whether it's profit or nonprofit, I'm not sure that's that terribly important, at least not on the discovery side. But it is important to engage all the stakeholders, or most of the stakeholders, right up front. And I think the comment about patient engagement and citizen right up front is a very, very important one.
So we're going to have another question, but I want you to be thinking about, because we'll get into the brainstorming session, I need you to be thinking about, as we've talked about these interesting things, how do we actually do those? How do we create the right kind of paradigm, the right kind of project, the right kind of model to actually see whether these work, or how you would create those, how you would look at one versus another model? So be thinking, please. Yes.
Don, good morning. Stephen Shrewsbury at Aquinox, and we are a pharmaceutical company, a biotech company, developing a Canadian-discovered drug to tackle a Canadian-discovered UBC, Canadian-discovered pathway in acute exacerbations of COPD, so your sweet spot.
Oh, yes.
And we were particularly interested, and we were very delighted to put together a bid with a proof center here to really look at how we could actually develop our drug specifically for the right patient to be delivered at the right time. But unfortunately, we didn't get the award for that. So my question to you and to others in the audience really is, how can industry really engage academia and government so that we can actually move forward in partnership? Because it felt as if we were rather closed out of that process.
I can't speak to that process exactly, but I mean, engaging academia is very easy, I think. We're one phone call away. And would be, I think, more than delighted to engage in kind of dialogue that would be constructive. I'm not so sure about the government, but maybe the minister can help us on that front. So I think it's a matter of discussing these things, and even good partnerships, even very good projects, don't get funded. And Jim Hogg is sitting in the back. I'm sure in his 40-year illustrious research career, he's had 1 or 2 grants rejected. So this happens to all of us. And people in academia really take that as badge of honor, that people actually read it and made comments. So we take rejection probably better than maybe the private sector. So I think it's a matter of, if you believe in the product or the project, and there's good partnership, just keep doing it. And then ultimately, there will be a time, the right time, when it will be funded, and then you can really accelerate the research project that way and deliver on that innovation. I wouldn't give up, for sure.
I'd like you, first of all, to thank Don, if you would join me, and the team that put this together. Thank you very much, Don. Appreciate it.